Zoom recording, and then we can let everyone in. Good morning. Welcome.
Good morning.
Morning. Good to see you.
We hope wherever you are beaming in from, it's warm and dry. Do we have any folks from downstate, and did it snow? Has it snowed? Brandy, snow?
It did. We are on our 100th million snow day down here, but at least this time we can see the grass, just freezing temperatures and icy conditions. So we're making it. We're thinking spring.
Hi, Brandy. I missed you.
Hi, Katie. Miss you too. Congratulations.
Oh, thank you. I wish I could show it off, but it's being resized, so.
So exciting.
Very unexpected.
Morning. Good to see you all. Hi, Dr. Berkey. Ms. McLaughlin, I saw your email about forwarding out the guide. We'll share the link in the chat today, and then if anyone else, we may send it out in different network groups. So thanks for bumping that up.
Yes, thank you. I'm anxious to see the new one, so that's great.
Good morning, MJ.
Hi, Deb.
Hey, Sharon.
Again, thank you for coming. If you all would sign into the chat, let us know who you are and who you're representing and what your special interest might be in the data or how you've used the data, that would be wonderful.
And we'll give it about 1 or 2 more minutes as folks are trickling in, and then we'll get started on time so we can end on time, right? Ms. Cornish, good to see you. You know how I am, Ms. Cornish. Start on time, we end on time, right?
My apologies for being late. I was
No,
on
no,
another
no, no,
call.
no. That wasn't directed at you.
And Miss Cornish is soon to be Dr. Miss Cornish, right?
That is correct.
Fingers crossed, yes.
Yes, Miss Capelli, I gathered that, so I was very excited for you. And your fiance, right? They're getting a good one, right?
I hope so. He's been sick in bed with, I call it the plague for the last week, but.
No. Oh no.
Yeah. But yeah, he's a good one.
I call it the scourge, but same difference.
Listen, I default cooties. Okay, everybody's got cooties, all right? And that's the official term. All right, folks. So we're gonna go ahead and get started, and we'll be letting folks in as we go through it. I wanted to welcome everyone to our meeting today. This is the winter convening of the State Epidemiological Outcomes Work Group. My name is MJ Scales, for those of you who I haven't met, but I've met most folks, and I'm glad to see you and glad to make new friends today. I'm joined, the team is actually Sharon Merriman and I, who is a retired scientist here at Center for Drug and Health Studies, as well as research associate Emily Rell and graduate research assistant Shauna Leahy. They're joining me today. We're going to facilitate this meeting and facilitate this conversation. We're fairly informal, so if you have questions, please add them to the chat. We are excited to talk with you today and share with you some different products that we've put out since we last met in September when we were talking about recovery. What I do want to do, though, is hold space for a moment. We'll talk about the goals of the SEOW here in a second, but what we do is data, right? We do data day in and day out. And I'm going to put this on slideshow so that it's easier for other people to see. We do data day in and day out. We share data, we make data products, and we understand personally and professionally that some of the things that are happening with data at the national level are concerning and make our jobs at the SEOW, but our jobs in this field more challenging, right? So we do want to acknowledge that that's not this conversation though. Okay, so our conversation today is a look back and what's happening in Delaware, and we want to lift that up. We understand that not having access to data is particularly challenging. We understand that what can be considered the erasure of data is problematic. But today we're gonna focus in on what we have today. I'm happy to have offline conversations with people about data they may need access to, data gaps that they may have. But our conversation today is going to be one that is focused in and locked in on the behavioral health landscape, excuse me, in Delaware, as we have put forth these data products. But I do want to acknowledge the frustration and at times fears and concerns that folks may have. As many of you know, this is a project funded by the Delaware Department for Health and Social Services, Division of Substance Abuse and Mental Health, or DSAM, through funding from SAMHSA, and we are grateful to partner with the state on that. Today, we're going to do some welcome and introductions. We've already done that. We will talk about the goals of the SEOW for anyone who's not familiar with the SEOW. We will share our data products that we've put together since the last time we met. We will go through some highlights from the annual Epi profile, some of the new things that we've done with that. And again, we continue to thank you for your feedback so we can refine and make the best products possible. Sharon will facilitate a conversation and discussion later on. And then as we always do, we want to hear what's happening with you all, any, events, what am I trying to say? Programming and so on and so forth. One thing I do want to share in terms of data, and I apologize for blanking on this, Shauna will put that link in the chat, is there is a bit of encouragement, right? So many of the data sources that we rely on may be unavailable temporarily, right? So we may have to be more creative in that and look to other sources like the Kaiser Family Foundation, like the Trevor Project, like Pew Research and state Medicaid fact sheets. So there is a list, a link that Shauna's going to put in the chat, and do some do some detective work on that. What I would encourage you to do though is just be mindful. Look at what are the data sources. Opinion polling is great, but again, it's people's opinions, right? So we want to make sure the Trevor Project, one of the reasons why I really incorporate their findings and some of the work that they do and work that I do is because they put their methodology out there. And I think that's super important, is that you know what exactly and how exactly people are collecting the data so that you can frame it in the right way. So we'll get into some of those discussions today about the Epi report, but if you want to talk more about alternate data sources, we can surely do that. Okay. All right, Shauna.
And yeah, as many of you may know, the goals of the SEOW include build monitoring and surveillance systems to identify, analyze, and profile data from state and local resources. We identify, share, and analyze data for everyone. We create data-guided products that inform prevention, treatment, and recovery planning and policies. And we also work to train agencies and communities in understanding, using, and presenting data effectively. So those are kind of all the things that we work toward for the state. And since we last saw you, first up, a reminder, we do have a newsletter that goes up every 3 weeks that includes various data sources, monthly observances, reports, and information about what we're doing and what we are seeing out in the field. So if you want to be included in that and you are not, you can reach out to MJ, and I'm sure she will get you on the listserv for that. We also have a new opioid infographic series we're working on. The first one is already out on the website. We'll share the link to that in the chat. It's on long-term impacts of opioid use. And then another one will be coming soon related to maternal and infant health. And then we have plans for future topics on the series later this year. And then today's topic and the data products, which the links will be shared, in the chat, or afterward, we'll send out a sheet with all the links to all of these. We have the 2024 Delaware Epi Report that we will be talking about today. And we have various things on the website related to the Epi Report. We have all the modules separated out. We have the infographics related to each module. We have a companion guide. We have an executive summary, which you can see on the screen. And then we also have a slide deck that includes all of the important graphs and figures that are within the Epi Report that you can share out to people as you see fit.
So what I also want to emphasize, to Shauna's point, when you get these slides, these links are live. They'll take you directly there. Shauna will also put them in the chat. Anything that's on the CDHS website is available for public use. The other thing I wanted to highlight here is a number of folks have already reached out to me for the SPIF PFS grant that is currently open at the state and the community level. We're happy to provide data to you, but you could also start here, and Shauna will put that link in the chat to see if the data already exists, and then you don't have to wait for MJ or wait for the CDAS team to pull it together. It may already be available online at a variety of different topics. And I saw... I don't see them here today. No worries. Dr. Berkey, how do topics get selected and do they address SHIP initiatives? So the topics for the infographics or the modules in the Epi report? Feel free to unmute her. Both. Okay. So infographics are created the topics are selected in partnership with DSAM since they are our funder, right? So we focus primarily on behavioral health and intersecting topics. So when we mean behavioral health, we certainly mean substance use, mental health, trauma, so on. And so and anything related to that, risk and protective factors, so on. So as far as the infographic, we look at what the priorities are for DSAM that year, and we create products for that. The Epi report is a little bit different, and I'm going to invite Sharon to speak on that. It's kind of evolved over the years, again, prioritizing DSAM's priorities, but also topics that we've heard from the state. I believe, Sharon, correct me if I'm wrong, gambling wasn't always in there. That became an emerging topic. It eventually got its own chapter, and the same thing with maternal health. Sharon, did you want to add anything?
No, that's pretty much the way that it has evolved. I mean, if you've been on these meetings before, you know that we invite the stakeholders in this network to share their data needs, and if they have populations or special topics that they're interested in, we want that feedback, and we try to incorporate that into our products. I think we've also included questions on this in several of our surveys that we've conducted over the past five or 6 years. So what we do is we look ourselves for the hot topic areas, but we also continuously request feedback from the network, and we take in the recommendations and the needs of our funders as well as other state stakeholders. So that's how it evolves. Generally speaking, once we identify a special topic, we follow it out until either there is not sufficient data to be able to report on, in which case we identify that need, or perhaps sometimes the needs aren't as great over time as they are when they initially arise. So it's a very organic process, Deb, and we would again welcome everyone's input into how we shape the data products.
The only other thing that I'll add here before we move on is that oftentimes it's also a matter of what data exists, right? So we sometimes would love to do maybe a feature or a chapter on something, but we wouldn't have enough, or there's not enough data that exists in the world to do a full module. So that may be where we do an infographic to highlight the data gaps, to highlight the data needs. All right, so the next thing we're gonna do is a little bit of an icebreaker. Just kidding. I always get nervous when people say, let's do icebreakers. No, no, no. So, but what we will do is we want to ask a question of the group. Shauna's going to I'm going to stop screen sharing. Shauna's going to put a link in the chat, and we want to hear from you. What comes to mind when you think of the Epi report? So that's a great segue from Dr. Berkey's question. So what comes to mind when you think of the data report? Is it, particular topics? Is it particular populations? Are there is it scary? For those of you who's been with us for a long time, you remember when the Epi report was one thing and it was about 300 pages. Still gives me nightmares at night, right? But we've been responsive to our funders as well as our partners, and now we have these modules that are very digestible. So I'm going to stop screen sharing for a second. Go ahead and use that link that Shauna has provided and add to it.
And I will share the word cloud as I see we're getting some people adding. Can everyone see that?
Yes, thank you. The prompt is what comes to mind when you think of the Epi report. And as we do that, I'd love to see a comparison of the co-occurrence between violence and substance use. That's a great intersection, not great, but there's an interesting intersection. We do have some information in there about some relationships. We did have a presentation, it might have been 2 years ago, Sharon, correct me if I'm wrong, where Gerald Chambers came in and talked about gun violence. We talked a little bit about substance use. We're lucky today in the conference room is Dr. Dan O'Connell, who is an expert on criminal justice. So if we have specific questions, we may be able to prompt him with the question towards the end. Otherwise, we can connect after this. All right, we're gonna give that about 30 more seconds. All right, so it sounds like folks, I love to see that it's relevant. That's excellent. That's collaboration. I really appreciate that. And this really is a collaborative effort, both internally, but also when we start looking at data sources. We rely, there's a great deal of data from the school surveys, which of course is led by Dr. Brittingham at CDAS. But that also requires collaboration with the schools. That also requires collaboration with the state as the funders of those surveys, and collaboration, within the schools to get it done. So I love that word. I love that word collaboration for the Epi report. If you have any other any other thoughts, feel free to add them to the chat, and we are going to move on to the next couple of slides. Better outcomes. Yes, thank you. Emily, you are up.
Yes, so we're going to talk a little bit about what the Epi report is. As Sharon and MJ mentioned, we do an annual Epi report that compiles data highlighting substance use, mental health, risk and protective factors, and other special topics, typically around behavioral health. The Epi report is a resource. You can use it for needs assessments, grant applications, evaluation planning, presentations, public awareness, and other media outreach. We do put it out every year. So our most recent one is from 2024. We can go to the next slide. We have 13 modules in the Epi report. The first one being e-cigarettes, vaping, and tobacco. The next being alcohol, marijuana, opioids, other legal drugs. And then we focus to maternal health, gambling, mental health and wellness, persons with disabilities, the adverse childhood experiences and other trauma, gender, sexuality, and protective factors. We are compiled of approximately 20 state and national data sources. This slide kind of goes over what all is available in there. If you actually look on the CDAS website, you can also go to visit all those data sources by the accessible links in the document.
One thing I want to add here is that if you all are familiar with the data set, you know, we publish this or we write this up every year. If you have a data set that you think it would be really beneficial for us to know about, feel free to send me an email, put it in the chat, and we'll, you know, take a deep dive into it and see where it aligns with, you know, the product itself.
And then as Shauna mentioned earlier, we are doing this infographic series on opioid use in Delaware. So our first one that was out looked at long-term health outcomes of long-term opioid use. We also have one on protective factors. I think someone noted this in the chat earlier too. If you click on the links, it will take you directly to the source. It also is accessible in that if you download the document onto your computer, it can be read through a screen reader and other resources in that regard. And those have also been shared out in our every 3-week newsletter. We try to put those in there so you can find them there as well as on the CDAS website. Next slide. Yeah, so we're compiled from over 30 state and national data sources. We include topics related to mental health, well-being, patterns of substance use and its consequences. We try to highlight issues that warrant attention and include populations that may experience disproportionate risk. And we have some guidelines for how we interpret data in our reports. So we tend to not report small numbers under 30. We do round to the whole. If there's missing observations, that's kind of all cleared out in how we do our methodology and then statistical significance and how we weight different forms of data. You can find all this in our methods section. And the companion guide also goes over how to interpret data as you walk through our different modules.
Thanks, Emily. So I want to pause here before we actually get into the data from the Epi report and see if there are any questions.
Do you have those 2 infographics from previous? Could you resend those out or through email, or do you have like a link to those 2? Or is that what they are?
Yeah, so if you look in the chat, a little bit ago, I think 10:12, Shauna put all the Epi report products right to the website.
Okay.
Yep. Yes, ma'am. So just for clarity, we have the Epi report. It has its own opioid chapter that we do every year. We do infographics for the entire report. Those are available on the website. This year, we took a deeper dive into opioids and are doing a series of infographics. So opioids and the long-term health consequences, because I think when people think of opioids, they think of death, right? But and the reality is that people deal with health consequences related to long-term opioid use that actually, and they don't die, not to be crass, but they may deal with heart, cardiovascular issues. They may deal with, you know, oral health issues and so on. And so we wanted to do a little bit of deeper dive just to highlight those things. Our next one out is maternal health, or maternal and infant health, what that means, you know, for folks who are using opioids while pregnant, so on.
I'm sorry, MJ. I'm still having a hard time finding the other.
Donna, can you redrop it in? Or she did right here.
Yeah, what in specific are you looking
products.
for?
Oh, just the 2 infographics that you showed on the the screen, the previous ones though, I guess were sent out. I just couldn't
Well, let's
find.
try
Yeah,
this. So
if
let's
you
do
click,
this. Can you all share, can you all see my screen? For the, let's do this. Give me 1 second. We'll do
Sorry,
some-
MJ.
No, you're fine. This is how we do. We do some on-site TA. So everybody can see that website, right? Our website.
Mhm.
So
Yeah,
when you go
that's
to
the
this
link I
link,
just sent in the chat.
yep.
Yep.
So this is,
Mhm.
I just pressed that link. This is the Epi reports and products.
Right.
Other things that CDS is doing across the top, SEOW is here. So this is the executive summary. I'm not going to click on it now.
Mhm,
The
mhm, mhm,
executive
mhm.
summary, the companion guide. These are all the narrative modules here on the left-hand side. The
Mhm.
corresponding infographics are here on the right-hand side.
Okay,
In addition to the infographics that we do for the Epi report,
got it.
we also do other infographics. So those are here as well. So our infographics, opioid infographic series is here. The slide deck. So some folks, or the PowerPoint, depending on generationally where you're at, are available online. Again, it's just the complete slide deck. So if you're doing a presentation and you want to focus in on, a particular topic, vaping or whatever, folks can just pull those slides. They're available for download. You don't have to ask us. You can just do it. And you can incorporate them into your slides. We just ask that you use the proper citations that are on there because we say where we got it from. So whether that's NISDA or the Delaware school surveys. Does that answer your question, Ms. Capelli?
Yes, I think so. I found at least two of them. So I found the opioid series, and then I
Yep.
found the
So the one,
opioid
yep,
use disorder in Delaware one. So I
yes,
think I can play around with it. I just wanted to take a look deeper at the
yeah,
opioid
for
use in
sure.
Delaware one. Thank you. I appreciate that.
Yeah, no worries. And then I think you also had a question about where we get our rate.
Well, I saw from
Mm.
suitors, so okay. And that's among those that are participants. Got
Yep.
it. 30 district. Okay, cool. Awesome. Thank you. I appreciate it. I like this. I like this. You know me, we have to create more infographics, as I told you. So this is great.
Yes. Well, thank you for asking that question. Hopefully that's helpful to some of our folks who are newer to the group, and that way they can navigate the website a little easier. I saw your question, Dr. Berkey, about disordered eating. Not at this time. That is not a topic that is currently included in the Epi report, but we could, kind of have an offline conversation, me and Sharon, about some different ideas related to that.
MJ, I just want to point out one other thing about the data sources that we cite. As you know, a lot of the data sources that are available online update at different time intervals. Some are continuous. So there are times where we will do our best to put the most current information available into these non-dynamic reports. I mean that in terms of these are things that are set. Once they're set, they're set. And so, for instance, if you look at suitors today, there's more recent data, I believe, than what was used when we compiled it. And that's just a challenge that we face. But when you have your dashboards, that's something that's much more easily updated because it's more automated. So thank you for raising those questions.
Yeah.
Katie.
And you're familiar with, I'm sure you're familiar with the dashboard, like Caroline's been working. Yeah. Okay. Cause we've even done some more stuff on there. So, I totally, anybody who wants to go to the dashboard, the My Healthy Community, substance use disorder part of the dashboard, who are not familiar on this group, it is pretty much up to date with anything that's public and available. So, just another resource.
If you wouldn't mind, Ms. Capelli, maybe for folks who are not
Sure.
familiar, we could put that link in the chat so folks can go right to it.
It's a tremendous resource.
All right, so one other thing before we get into the data itself, we wanted to, in the report, we make a note about word choice. And we understand how, first of all, important language is important, how we frame things is important. That drives funding, it drives our feelings about the thing, it drives stigma, frankly, if we're using language. We use language that's accurate, respectful, free from stigma, strength-based, trauma-informed, and inclusive and culturally responsive. However, as Sharon pointed out, we pull data from other sources. So if we're using a source where gender and sex are a binary, then we are limited to how the data is collected by that source. So it's important that we understand where the data is coming from. and where, you know, the context around that data. So we just want to make that clear for folks. When we create products, we have a freedom to do that. If we're pulling something down from, say, you know, Burfus or whatever, we're limited to how they use it or how they collect it. So again, happy to get into that more with some folks. If you read our reports and there's resources that we can share or resources that you'd like to share with us, we're always learning alongside with you. All right, so let's get into the data. That's what we're here for, and then we'll follow up with the focused conversation, you know, discussion facilitated by Sharon. One of the things that we focus a lot on is e-cigarettes and vaping. And what's interesting about that is that despite declining rates of tobacco use, nearly 1 in 5 Delawareans 12 and up still use the tobacco product in the past month. About 6% of Delaware adults reported that they currently use e-cigarettes, and about 1 in 4 11th grade students report that they use e-cigarettes or vaping device any point in their lifetime, and about 10% in the past month. What's interesting about this data is, yes, there's the health implications, but what we hear from our DOE partners is the relationship to disciplinary data and actions and so on, the disruption to the school day. So there are the health implications to vaping and to smoking and so on. But really, what's interesting, and I don't see any of my DOE partners here today, the implications for vaping in schools as it relates to instructional time, as it relates to discipline, and so forth. So this is a priority topic for folks. We know that there is a relationship, different groups use tobacco products at different rates. And within the report, we get into that a little bit as well. And sidebar, when you get these links, these are all live links. So if you want to, see the data for yourself, we certainly encourage you to do that. One that, doesn't always get attention, but we're going to keep beating the drum is alcohol, right? Shauna's going to put it in the chat. There is a recent Surgeon General's advisory that talks about, the relationship between alcohol consumption and cancer rates. And so while alcohol is oftentimes, alcohol use may be minimized and I say that in the sense of it's not as acute as deaths related to fentanyl and opioids and other things. That is in fact true, but we know that half of Delawareans age 12 and older used alcohol within the past month. Binge drinking rates are highest among the 18 to 25-year-old age range, and nearly 1 in 3 in this group within 18 to 25 reported binge drinking. And then more than 40% of Delawareans perceive drinking 5 or more drinks once or twice a week to be a great risk. So we start getting into binge drinking, heavy drinking, and how people perceive if that's problematic. And there's a great deal of research and studies that the CDC has put out, which are actually still available on the website, about, is it 1 drink a day? And when we talk to young people and even adults, can I save all my 1 drinks a day till one day, to just Friday, and then have 7 drinks? Is that the same thing? So when we talk about how people perceive risk, it's important that they understand the risk related to the patterns of alcohol consumption as well as the amount. Marijuana is, what we do at the SEOW is, we share data about marijuana. We don't make judgment calls about marijuana. Nearly 1 in 6 Delawareans age 12 or over used marijuana in the past month. Obviously, there's been recent legislation, and we do touch on this related to recreational purchase and consumption. The state is shifting in that way in terms of licensing, and that's still it's still in process, let's say. But 1 in 4 11th grade students have used marijuana in the past year. And 39% of 11th grade students report using marijuana in the past year. Those same students reported experiencing 3 or more adverse in childhood experiences. So one of the things we talk about in the Epi report, which is super important, is a relationship between risk and use. And specifically the chapter on ACEs, you'll see that there is a relationship between the number of ACEs and reported use of different substances. Opioids, we've talked about that quite a bit today, but the rate of people in Delaware filling an opioid prescription has declined since 2015, decreasing from 20.4 to 11.6 per 100 residents, which is, that's exciting. It's great. I think that, partnering with physicians in this work is super important. It's not just the work of, say, DSAM or substance use counselors. It's really important that we're partnering with everyone from our physicians to our dentists to teachers and educators around and even SN4C with their deterra bags and responsible disposal of opioid prescriptions and all prescriptions in general. So we do talk about that a little bit. That's an important metric. And we've already talked about suitors, but we'll talk about it again. Delaware's 2022 drug overdose mortality rate involving any opioid was 50.5 deaths per 100,000 residents. This is the second highest rate among the 30 jurisdictions reporting. So not everyone reports, but we are unfortunately the second highest rate among the 30 jurisdictions. So it's important to understand what that means. I'm happy to dig into that if there are any questions. Other illegal drugs. So it's estimated that about 3% of Delawareans aged 12 and older used an illicit drug other than marijuana in the past month. So what I really like about NISDA is that when you include marijuana, that number is a little bit higher, but due to different regulations and legislations across state, they also provide a data point that doesn't include marijuana. And the highest rate of reported use was in the 18 to 25 age group. And our second to last slide is on mental health. So we have a whole chapter on mental health, and it's estimated that 36.14%, excuse me, of Delaware adults aged 18 to 25 had a mental illness in the past year. So again, I want to highlight language, right? Because we talk about major depressive episodes, we talk about mental health challenges, we talk about behavioral health issues, we talk about substance use disorder. The language here is from NISDA. And according to the Division of Forensic Sciences, there were 145 deaths by suicide certified in 2023. And among 11th graders, 1 in 5 report feeling down, depressed, or hopeless on more than half of the days in the past 2 weeks. And that's typically used as an indicator of depression. And our last slide on the data, and then we'll check in with any questions before Sharon starts, is we do focus on particular populations within the Epi report itself. So we talk about there are the LGBTQ plus individuals, that's how it's framed. And again, to what I said earlier, but also to Sharon's point, that shifts, right? Because some data sources only ask about sexuality. For some data sources, that Q is questioning, some it's queer, some it could be, so it's important that you have that framing, and really it is honestly data source dependent what's included in that. But according to the 2022 Burfus, about 46% of Delaware adults with a disability ever report having depression, compared to 14% among other adults. We highlight the population of individuals with disability because they are a population that is often under studied, under surveyed. Folks tend to see the disability and not the person, and so therefore we don't go deeper into whether or not a person is also struggling with smoking, right, or struggling with depression, or may need behavioral health resources related to substance use. So that is a population that has its own module, and we felt like it's important to dig into that a little bit deeper, because it is a population of folks who are often underrepresented and under asked about their behavioral health status. The 2023 DSS indicates that 8th grade LGBTQ students reported nearly twice the rate of recent use of alcohol, marijuana, and vaping products compared to other students. We highlight this in the Epi report, but I'll say it here, and I'll say it every time we talk about this topic. When we write the report and we look at the data, we want to emphasize that it is not the nature of being a member of this community that puts folks, let me put it another way. I'm not using more drugs because I'm gay or because I'm trans, right? Oftentimes it's related to external factors that lead to feelings of isolation and depression and different policies or legislation that may, I may have fear and concern about, which leads to coping in this way. So that's an important thing that I always highlight. It's in the Epi report. It's important for folks to consider that when they think about data for this particular population. And approximately 39% of 11th grade students who never or do not often feel safe at school feel anxious, and that's probably not surprising, right? Compared to 23% of students who report feeling safe. So kids who feel safe in school are less likely to feel anxious than kids who don't. Okay. So I want to pause here. I want to, take a few minutes to talk about any questions that folks may have, whether it's how we got the data, what the data means, or where they can learn more.
I'm seeing a lot of discussion in the chat about the suitors database, and I think this is really, an important illustration of just how challenging it is sometimes to capture data at a given point, because some of these dashboards are continuously updating. They certainly update from year to year, but it also depends on when states can get their data in. And so there's a bit of a shift in some of these things. If you happen to look at the suitors database, they do give you options to look at different years, but they also have different categories of types of abuse, of overdose, excuse me. So there's a lot of nuance here. And if at times you look at something we've got and it isn't what's currently on the website, that might be why. But we do our best to be as accurate as possible when we're creating the data points. I think it's amazing that we have some of these sites available to us to be able to look at. And it seems to me that over the time that I have worked on the Epi report, which goes back to like the early teens, okay, more and more and more of these databases have become available through public websites, and it's a wonderful tool to be able to go to these and see much more current information than we used to be able to pull. So just a little note there. But
Yeah, I want to piggyback on that, Sharon, because TEDS is a good example of that. So for folks who are not familiar with the TEDS data set, it's a treatment episode data set that looks at admissions and discharges for state fund, in some cases state funded and in some cases all funded substance use treatment. And they will continue to take, so right now if I download the data set, it says this, right? But the reality is SAMHSA will continue, and this would not, let me pick a different state. If Texas said, hey, we found this box of treatment admissions from 2013, will you take it? They'll take it. And then you would upload your data. And so then that would mean the data would look a little different when that data is imported into the system. So, we pull it at a particular time. That's why we do the year before, because we hope that it's been cleared, it's not embargoed anymore, any bugs have been worked out. For the most part, the year before, the most recently available data. But it is possible that data continues to be updated and refined. And so 6 months from now, these numbers may be slightly different. And typically it's a small difference, right? 40%, 42%, not 40%, 95%. Okay. Any other questions that folks have on adolescent health, wondering how you made the correlation between sleep and injury-related risk behavior? It seems a stretch to say, what infographic are you referring to? Because I don't have a YRBS infographic on adolescent health.
Sorry, yeah, I was looking at, yeah, you do. So I was just looking at it. But
No, I meant for the Epi report. There's not one, so
Oh.
you have to reorient me. I'm sorry.
Well, I was on your main webpage and just poking around.
Yes,
And I
ma'am.
guess it came out in MMWR 2007 through 13 study. It just does seem like a stretch. They did a study and they determined, that this many people weren't getting that much sleep. And this many people were drinking and driving, and they put the two together. But I don't see how they decided that they were linked that way,
Well, see, so that infographic was done a long time ago. So I'm having to
Sorry, I
reread
just-
it. I'm having to reread it myself. What I
I'm like
will say
throwing
to
stuff
you-
out at you that isn't anything to do with today, so that's fine.
No, that's fine. What I will say to you is I'm again reorienting myself. What I will say very likely is that oftentimes we can't do things that are causal, right?
Right.
The SEOW is not a primary data collector. So we are relying on the data collected by others and we're reporting that out. What I'm remembering from that particular study is there was a relationship, but it was not causal necessarily, right? So students who report this were more likely to report this. So kids who report sleeping less than 7 hours more likely to report, you know, not using their helmet. So they asked kids, the on the YRBS, the last time you rode a bike, did you wear a helmet? Then they asked kids, you know, how much sleep are you getting? And in their analysis, I believe that was Wheaton et al., they found a connection between those things. And there is some, you know, when we don't sleep well, we don't make good choices, right? So I'll say that for now, keeping us on track for time, but I'm happy to dig into that with you more about that particular infographic.
Thank you, though.
Yeah, no worries. Sorry, I was like, what infographic? From when?
I know.
Right. And the other thing, to Dan's point, is we at the survey asked, do you do a thing? And then we asked, do you do another thing? And we do another thing and another thing. One of the things that's interesting about that infographic that we found when we were creating it is there's almost like a if you get too little sleep, you feel sad. If you get too much sleep, you also feel sad, right? So there's this sweet spot of sleep, right? But am I sad and that's why I'm not getting enough sleep? Or am I not getting enough sleep because I'm sad? Which way does it go? Chicken and egg, right? And we see this a lot related to mental health and substance use. Am I depressed because alcohol is a depressant and I am drinking a lot and therefore that's why I'm depressed? Or am I already depressed and I'm using alcohol to manage those emotions? So unless we ask people that, sometimes it's hard to know from surveys. Thank you. I'm assuming it's Dr. O'Connell. Apparently he's getting all the credit for whoever's in the conference room. I thank you for raising that. So Ms. McLaughlin, you have my email. You know, we can connect offline about that. That wasn't me. That's unfortunate. You got the credit though. So, all right. So let's get any other questions about the Epi report, Epi products. I want to highlight again, the university has moved towards anything that's posted on the website to be accessible with readers. And so all of the products that are posted this year, we didn't go back and redo them, but probably within the last year, 18 months, that the SEOW is creating them, they have to pass certain accessibility features like, you know, through Adobe, through Word, through all of those different measurements. So if you have questions or you want to use those products, that's something to think about. Okay.
Can I make a suggestion?
Yes, ma'am. Sure.
On your website where
Yes,
you've
ma'am.
got the list of all the SEOW infographics, and some of them next to them you said new, could you add a date? So it just would, some of them have a date. The infographic on crisis text line has a date. But not all of them do. So that would sort of give the viewer, without having to go in and look and then come back out again.
Yeah, that's definitely a good idea. We'll look at that. Oftentimes it's in the file name. So if I click on Veterans and Behavioral Health, it'll tell me in the address bar that was made in November 2023. But I see what you're saying in terms of having it in the name of the file itself. That's something we could do moving forward. It would probably be a different kind of a lift with IT because I'm not the IT folks. But it's something we could do. We could try to incorporate moving forward. Thank you for that. Any questions about, sorry, looking over opioid overdose deaths from research, we were number 2. Okay. Yeah, no, listen, this is one of those cases where being number 2 or number 3 is not ideal either way. So I think what you're saying, I thank you for sharing that. So any other questions about the Epi report before we get into our discussion today?
I just have a comment, MJ, because I've been taking advantage of this data for years, and I love the infographics. It makes my life easy, especially when we're doing school level or college level presentations. I just pop those infographics right in there and say, let's look at this. And then we have a discussion, and I don't have to do a lot of talking. I also use some of this information when I'm writing work plans, IOM work plans for some of my block grants. I use one of your infographics and I popped it in there for needs assessment and how we're tracking data, because all of my programs are pretty much data driven. So I'm so grateful for them. I know that we had a drop in our data that we collect from one of our SAMHSA grants during COVID, because we didn't have access to kids in school when we were doing our pre and post tests to determine the rate of change. We did try to do virtual with them, so the numbers were a little off from previous years, but now that we're back. So some of those things can happen where data can be interrupted based on what you collected before that interruption. But I you know how I feel about you guys. I got a certificate, so I'm a data champion, so I can speak to that. But I rely a lot on the data you collect, and I appreciate your efforts in doing it.
Thank you, Ms. Cornish. I appreciate you. And I know I could speak to Sharon. She, over time, one of the reasons why the Epi report and the slides and the infographics are successful is because of stakeholder feedback, like yourself coming back and saying, this is working, this is not working. The team that's been with me here now for a couple of years knows that I'm like, nope, that's not working for folks. We got to do it differently. Nope. I don't, that's not working for the state. That's not working for the team. We got to do differently. Or, hey, folks have given us this feedback. Let's see what we can do. And so I'm very privileged to be a part of the SEOW, and to be responsive to folks is a blessing. But I also appreciate that feedback. And so that's why I hear you. And I also hear Ms. McLaughlin. And so we'll definitely take a look at those different things. But thank you for that feedback. Were there any other questions, comments, concerns? MJ, we don't want you to do a slide deck. We want you to come and present it yourself. That's fine. You can do that too. Whatever you need from us, we're happy to help. I say that, and then Sharon's like, oh boy. Because she knows I always volunteer for more work. And she's like, no. So, all right. So we're gonna get into the discussion that Dana, not Dana. I don't know why I'm thinking about Dana. Hey, Dana. I saw her come into the room a few minutes ago. And that Sharon's gonna facilitate. Sharon, I'm gonna your boss does that all the time? Yeah. Sharon's been telling me that for years. When she was full-time, she would say, you go to these meetings and you come back and you've got more work. How did you do that? You were just supposed to go and present the thing. And I was like, I don't know. It's more work. And then Emily and Shauna are like, what in the world is going on here? All right. So getting us back to the slides. All right. Give me 1 second, Sharon. I got you.
No,
All right.
that's great. Thank you. I just want to say that I appreciate the complexity and maybe the thorniness of the conversation we just had, because, I think that's what this group is supposed to do. We're supposed to raise questions about the data and how's it collected and why is this presented this way and why is this different than that. And, I think first of all, it keeps us on our toes, but it really highlights how challenging it is to accurately collect and report data, and to do it in ways that are, that are not misleading. I served for a long time in a National Center on Elder Abuse, which kind of is a segue into what I'm going to talk about next. And, folks would ask us questions about the data, and we would have to say the data is very, very scant. And we would take great pains to put it out there in the most accurate light possible. And then I would invariably read a complete misconstrual of what I had said. So it was like, we do really want to be as accurate as possible and go back and make sure that we're talking about all the caveats that go along with using data when we do put it out there. But as I mentioned, I worked a lot in the field of older people. I was a mental health counselor for many years, and I ended up working a great deal with geriatric psychiatric issues. I'm no longer practicing as a therapist, but I ended up then working in the research field of elder abuse, and I still wear that hat. And so frequently you will hear me be the voice in the room saying, but where's the data on the older individuals? Because we don't always focus on this population. So you've seen MJ walk through the highlights of many of the modules of the Epi report from 2024. And she did mention that we do occasionally have populations where the needs have been greater, and we have focused on those and broken out a module specifically dedicated to folks in that group. One of the groups we haven't done that with is older individuals. We have done some infographics on this population. And I'm going to give a bit of a deeper dive than we have before. It's not going to be too deep, and I'll show you why. But we're going to talk a little bit about the behavioral health of older individuals. In the past, I think it was about a year ago, we had Dr. Ellison, and I think a number of you folks were on that call, where Dr. Ellison came and talked about behavioral health in older Delawareans. He was an expert. He is an expert. He's up at Jefferson now, but he had previously been at the Swank Center, and he talked a lot about some of the challenges of behavioral health in older individuals, focused in on what we know about folks in Delaware. And what I would like to give now is a bit of a spoiler alert, in that when we come to talk about substance use, the rates of substance use among older individuals is generally lower than the general population. So why then is this an important issue? And folks can either unmic and give their thoughts about this or pop in the chat, but I'd like to know why you think, I think it's a topic worth diving into.
Sharon, while folks are collecting their thoughts, could you kind of expand on what you mean by older adults? Are we talking 75 and up? Are we talking middle age? What are we talking about?
Oh, that's a really good question. And different data sources will treat people different, like we'll categorize people differently. Sometimes we're talking about people over 50. Sometimes we're talking about people over 60. We try to stipulate what group we're talking about in any individual case where we're reporting on data. It depends on how the data is collected and how it's analyzed, to be honest. But I can tell you that starting at about age 50, individuals have physiological changes in their body that create different challenges for folks in terms of how they process substances. So we can sometimes look at that group, but generally speaking, as we age, our bodies change. So we're starting to talk about people about 50 and older. Is anybody aware of why we might? I just gave you a big clue. The body metabolizes substances more slowly as we age. So that's one reason why we might want to look at this population. Any other thoughts about this?
I have some thoughts, and I'm glad that you are discussing this, because I have crossed the threshold into this group of people. And I notice when I go to the doctor now, I'm the baby in the waiting room. But I think it's important because people who I know, and for myself, who may have had to have medical procedures that require pain relievers afterwards, I have to inform my doctor, I cannot do narcotics. You have to come up with some alternative for me. But not everybody is in tune to some of the risks of using opioids. Like my sister, she had surgery and she's like, oh, they gave me all these oxys. And I was like, let me have a teachable moment with you. And we had a conversation, and she went back to her doctor and said, I don't want to risk it. Is there something else that you can give me? And then you have to be careful if they are taking any type of pain reliever that can be addictive. Are they also drinking? I'm finding, just in conversations and being out in communities, that older populations are starting to use marijuana as a substitute to relieve certain pains. I have arthritis, I'm a breast cancer survivor. I get migraines. So they get their medical cards, and now they're out there vaping. But what other medications are you taking? Is there enough research out there yet to say, okay, you're vaping, you're vaping an acetate or you got it off the black market and you're taking blood pressure medication, how is that interacting? And is that going to be an additional risk to your health? So thanks for doing this topic.
Thank you, Dion. And that was a really great intro because you touched on so many aspects. There's the possibility of drug interaction. There's the possibility of interaction with various health conditions. And Katie wrote in the chat, dementia is a huge issue as we age, and the interaction of opioids, the ability to be able to use your medication appropriately as you start to have cognitive impairment, if you start to have cognitive impairment, the greater risk of developing an illness or of developing a disability as we age, and the needs that come along with that. There are so many different interactions that go on with this that that make it really challenging for those who may have a substance use problem. And I think behind all of this, we're talking about the fact that the population is aging. And Dion, come sit by me because I way crossed that threshold. And it's like, oh man, now it's about me. It's really personal, the resource base is pretty small for specialized treatments for older individuals. And not only is the population aging in general, but in Delaware, we are actually a retirement destination for a lot of reasons. So it is it's a topic that is particularly important because the folks that it does affect, it affects a great deal. So if we can go on to the next slide, MJ.
Yes, ma'am. The other thing I want to say that I hear a lot from our prevention providers is that a lot of older adults are caring for their grandkids. And what does that mean? And what does the impact of that? And we talk about this a lot with women and moms and things, but I think it's important to highlight that as well, as many of our older adults, our grandparents are raising their grandchildren rather. And so that has some impact on their health overall, but also their behavioral health is super relevant.
Thank you. And yeah, and they're caring for older people, they're caring for younger people. It's a challenging phase of life. And I like Karen's comment, and I agree with it. Even my caffeine consumption had to change due to age and interaction with other meds. And yes, again, I'm right there with you. So here's the spoiler alert. There is not a lot of data that we have on older individuals, but the Behavioral Health Risk Factor Survey surveillance system does actually capture a few data points that we can report out on. And so when we look at folks who are 65 and older from the 2022 survey results, we had a vaping and tobacco rates reported, and 1.2% of individuals in that age group reported that they're current e-cigarette users, and 7.7% identified as current smokers. Now, these are considerably lower than the general population, but still, you've got 1 in 100 individuals in this age group that are actually currently using e-cigarette products. In terms of alcohol, nearly half, 46.3%, report having at least one alcoholic drink in the past month, and 1 in 20, or 5.6%, reported binge drinking. Again, these are lower rates, but you can see that with the other things that we've talked about, these could create some particular issues for the folks that are imbibing. So if we'll go on to the next slide.
Yes, ma'am. Would you give me one moment? The conference room has some comments. They are unmuted. I don't know why they think that they are muted.
Can you hear me?
Yes, ma'am.
Okay. One thing that I wanted to add is that I do research on the elderly too, and the problem with every report that you see is you see these incidence rates for those over 65, 70, etc. And while they're low base for victimization, for offending, for all sorts of things, when you get into it, so the etiology, we know the low base rate, but the epidemiology we know, but the etiology tends to be almost for every behavior completely different. And like victimization, may have a low rate, but the people they are vulnerable to are extremely different than any other age. And that goes for behavioral health outcomes. The etiology of an older individual drinking or having depression or it is different because their social world is different. And I also am carrying an AARP card. So I'm aware of that individually, but that's one thing I would like this group to look into too, not just the rates of stuff, but what are the correlates? Because they tend to be much different than younger folks, and that would be important to know, I think.
And that, I think that's a great point. And that really speaks to me to the need of another area of your specialty, and that is qualitative research in these areas, where we can really dive deeper. I like to say, the survey work is great for identifying things, but it doesn't often allow us to really do the deep dive into what is associated with that. And we're gonna skip to in a couple of slides. We're gonna get to that, get to something that's very related to what you're talking about, Ronette. So, was there another comment?
Karen McLaughlin asked, do you feel the data was impacted by the COVID epidemic?
Well, all I can say is that, I mean,
The
in the one,
shorter answer is yes, everything was affected by the COVID.
yes, I mean, what has it been? Behaviors were probably as well, but I mean,
Yeah,
one thing
just wondering
about the
if you
Burfus.
compared years, because I know in other age groups it's been highlighted that there was more drinking during when people were in lockdown, but I have never heard where they plucked out, the senior group and said this group also had XYZ reaction.
I really haven't seen that either. But I think that's going to be in part due to data challenges that are related to working with this group. One thing about the Burfus is that it's been a phone survey. It is a phone interview survey. So it was a phone interview survey. It didn't change the data collection method didn't change. I mean, the data collection method has changed over the years in that, now we've incorporated cell phones and things like that. But it didn't change particularly in terms of as far as I'm aware, I was not made aware that there were any differences in the methodology for that. But good question. We can go on to the next slide. So earlier in the presentation, MJ talked about TEDS data, which is the treatment episode data set for publicly funded treatment. And we do have data for Delaware for 2021, and it is collected, as you can see, it's collected in pretty small age group sections, if you will. So, obviously, as we look at the far right of the chart, people aged 51 through 66 and over actually, for the most part, are at lower rates than younger folks from the 26 to about the 41, 45 age group. But still, it's not an inconsiderable amount of folks that are being admitted for treatment that are at the older end of the spectrum. So one thing I would like to point out here is that, it's like here we get to 66 and over, and it's like we drop off a cliff. We know people are living well past 66, and just from daily observation of life, we know that the needs of people who are 66 can generally be very different than the needs of people who are 80 and 85. But for purposes of analysis, I think that the data is grouped this way. So you can see that there are people 66 and over who are being admitted for publicly funded treatment in the state. Go to the next slide, MJ.
Yes, ma'am. The other thing I want to point out real quick is that we did put, Sharon has referenced Dr. Ellison's presentation from last January, and it does get into a lot of what Sharon is discussing today and some of the challenges, right? You know, are folks depressed or in a clinical depression, or is it more related to the fact that many of their peers are passing away and so on and so forth, and it's more grief than depression. So he goes into all that. That link is in the chat as well, as Sharon's referencing his presentation.
Right, and I will also point out that there are other data that are out there that I didn't include in today's highlight, but that I'm strictly drawing on today what we have in the Epi profile, what we've reported out there, since this is the topic for today. But I also want to mention that an area that's overlooked, I think, many times is that, you know, when we think of trauma, quite often we think about younger people. We think about ACEs. We're not necessarily as inclined to think about trauma experienced by older individuals. And so there were just a couple of data points that I pulled out from the report that I thought were of interest. And that is that, you know, 9% of the 54 deaths by homicide that occurred in Delaware in 2023 were of individuals who were age 60 and over. That's not an inconsiderable number. And then the other data point is that 16% of gun violence victims in Delaware, according to the database that used to be online with the Delaware Online, Delaware News Journal, they tracked gun violence. And in 2024, 22 of 134 gun violence victims were age 45 and older. Again, I think we tend to think of younger folks being the victims of gun violence, but trauma impacts older individuals as well. So there are national data available from the NISDA on mental health and older individuals, but it is not broken down by age group that we can report out on for Delaware specifically. So I did not, that was not something I included in today's discussion. But what I would like to do briefly here is just ask if any folks, you know, like, what do you think are the data challenges? And we've touched on some of this, of looking at this population. Any thoughts?
So one of the challenges I'll highlight is what I asked in the beginning is, what do we mean by older, right? Because to your point, folks are living much longer. It's not you know, uncommon to find folks living well into their 80s, 90s, and beyond. And so the experiences of those folks are obviously much different than 60 folks who may still be working, people are working longer, so on. So one of the data challenges that I sometimes have is, what do I even, let's start there. What do I even mean by older adults? And what do, if I'm using someone else's data, what do they mean by older adults?
Right, right. The other thing that I think of is the reason we have so much more youth data is because we have youth in schools. And we can go to the schools with varying degrees of success and survey students. It's a challenge, of course, but at least there's the place where we can go and survey folks. But we don't have the equivalent of that in terms of even gathering adult data. We have the BRFIS, we have the NISDA, but if you wanted to focus on the needs of older individuals, it's much more challenging. And you have issues around accessibility, you have issues around cognitive impairment that may impede their ability to even participate in research. So it does become a challenge to accurately get this data.
I wonder if we just need to get more creative, and you know, we already collaborate. You have lots of partners. Just the way we collect the data, I don't know if there's partnership with the Department of Transportation, for instance. If you want to renew your driver's license, you have to complete this 5-question survey. You know, things like that, or, you know, go to where people are already going, which, you know, is talked about a lot, but I don't know that we've used that lens with people who are considered, you know, our seniors.
That's a good
Just a
thought.
thought.
That is a good thought. And I know that there have been a number of initiatives in, you know, healthcare settings. Um, challenging. It's challenging to get partners in that, you know, to engage in that, and then it's difficult to necessarily be able to give surveys or what have you in those settings. But those are also opportunities, I think.
I think as health professionals, we also, once we get an opportunity to do a survey, we want to ask all the questions because we're just so happy to have you, you know, listening to us and filling out our survey. And I think that maybe less is more in that case because people get surveyed out. And we're working on a risk assessment survey right now. And I keep pushing, you know, it's got 50 questions in it. And I'm like, really, folks, can we consolidate that? Can we make it simpler? Um, I know that there are um, groups, bots, whatever, you know, and so you get hit with surveys all the time, some more useful than others. But I don't know. Just it'll definitely take some brainstorming.
And I see that Kelly and Brandy in the chat have also identified, you know, for surveys that are, you know, online based, or they can be challenging. The navigating technology can be challenging. So these are some other challenges, but I think this is great to think of creative solutions. Thank you for sharing that, Shauna, the substance use risk and protective factors for the older adults webinar today. And Karen, I'm going to ask you if you would pop in the chat the link to the resource guide for older Delawareans.
Oh, right.
That would be great. It's very timely. You know, the other part of the equation is that we don't necessarily have folks that specialize in being able to treat older individuals in terms of behavioral health. We talked about that at length with Dr. Ellison last year. So again, an area of need that we can certainly identify. Did anyone else want to say anything more on this topic before we move on to just updates from the group? Because we want to always have a portion of our discussion where we can share out what's happening among your different agencies and organizations.
So one thing I'll say, Sharon, you know, being respectful of time, is that I think we also, when we talk about our older folks, in my church we call them the more seasoned saints, right? Is a cultural shift about valuing, at least you know, in this country, a predominant culture, valuing our older folks, right? Valuing our elders, because as much as we sometimes want to take data from them in terms of research and science and so on, they have a lot of life lessons and things to share, where, to Ms. McLaughlin's point, we can be creative. Is it cross-generational work? Is it cross-generational prevention efforts? Is it recognizing that older folks are, well, you know, it's not really relevant anyway. They got quote unquote old people got issues anyway, right? But understanding that our older adults have a right to a high quality of life and aging with dignity, for all the days that we all have. And so I think there has to be in terms of protective factors, a cultural shift around valuing our elders and valuing the voices of our elders. So that's what I'll say about protective factors before we move on.
That was a great point. And thank you, Dion, for also mentioning that. I'm grateful that that's an area of focus. Okay, so let's open up the conversation to what you all have to report on, because this is your network.
Yeah, that's a great idea, Ms. McLaughlin. I know that Planet Youth Coalition and Edgemore Community Center, one of the things that they do is they have folks, they have a mobile food pantry that folks come through and you know, they put surveys and flyers and things in people's food baskets or while people are lining up. I volunteer sometimes with the Food Bank of Delaware, and you know, people will say, hey, can I talk to you about this real quick? We can get you registered to vote real quick. We can, while you're waiting, you know, the long line, you know, we can get you started on, you know, a winter code or whatever the case may be. So thank you, Shelly Lazarchek, for sending out some upcoming conferences. I appreciate that. If you want to send it to me or Sharon or both of us, we can make sure it gets out. So thank you.
And thanks for sharing the resource directory, Karen, and also Dion for sharing the vaping in schools in the chat.
That's the second part to what I sent and it didn't attach it. We are looking at vaping. Tall Cop, which is a gentleman who's a retired police officer, does a lot of the environmental scans on the national level, and he keeps us updated on what the trends are, and he is seeing what we're starting to see in Delaware, that vaping, we're in 2 middle schools right now, doing prevention on vaping, has become like a public health concern for the staff and those of us who are in there with the kids. So we're trying to provide them support. And also this year, we will be implementing the alcohol intervention matrix. I left the link there. It's really great because we have a prevention academy that we do in partnership with DSU. So some of those students this year will be involved in assessing their campus and doing the intervention matrix and sharing that data with the staff there, public health.
Thank you for that. You know, it's just as I always think when we look at the Epi report, and we focus a lot of discussion on opioids, and rightly so. But when we look at the data, alcohol is still very prevalent among our youth in particular, and our other age groups. So it's important.
It's easier to obtain too.
Yes. Yes. It's much easier to obtain. So it's important not to forget about that when we think about these health issues.
So I put the URL for the Delaware SHIP in the chat. The Delaware SHIP, if you're not aware, is the State Health Improvement Plan. We recently, I say recently, it's actually a little old by now, but it's recently finally approved the Delaware State Health Assessment. One of the problems with collecting and distributing data is the process that it has to go through to make sure that it's as accurate as possible and reviewed by the appropriate agencies. And sometimes that takes forever. So we do have the SHAW State Health Assessment approved and posted, and the SHIP, the new Delaware State Health Improvement Plan, will be, it's under review and will be published very soon as well. And then these things go through regular continuous updates. And we have a SHIP coalition. If you haven't considered joining, I highly recommend it. This is where your agency and yourself can have your voice heard, and you can contribute to the talk and efforts on health priority in the state of Delaware, and you know, affect change on what are the priorities. And when you determine what the priorities are, as all of you know, that's where the resources go. So everybody should have a voice in that process. So we have some great teams that are working very hard under the SHIP coalition, and I highly recommend that you go out to the website and think about joining that.
Thank you for sharing that, Karen. I appreciate it. Brandy, you put in the chat, Tall Cop is a great presentation. Did you want to comment on that?
Sure. Dion had mentioned the Tall Cop presentation. Jermaine Galloway, we had the honor of seeing him present prior to COVID, and he was at Wilmington University in Dover. He brought materials that he purchased at vape establishments right down the street the day prior and showed what was being sold in our communities. In addition to his presentation, though, if you follow him online, he shows like these look like two identical phones. One was a vape device, one was an actual phone. It was quite alarming to see, but he goes, this is what's happening in our schools. So I definitely promote the presentation. I would love to see it again because I know things have changed drastically since the last time I saw him present. But if you can't see him present, at least following him on social media, you will still get to see all of the great information.
Thank you.
You're welcome.
Any other updates or notifications that anyone wants to share?
Can I share something really quick?
Absolutely.
MJ, thank you for the shout out earlier with medication disposal. The DEA National Take Back event is happening in April, Saturday, April 26th from 10 to 2. Excuse my at-home snow day office assistants who are very hungry. But this is a national event, and I'm going to put in the chat the DEA National Take Back collection locator so everybody can see their nearest Dropbox location. And you can share it on social media as well.
Appreciate you, Brandy. I don't know what's on deck for lunch, but I appreciate you sharing with us either way. So thank you.
Thank you.
Anyone else? Anything else going on here in the great state of Delaware? Thank you. Thank you. Thank you.
I'm just going to mention that in May, we observe Trauma Awareness Month in Delaware. I think it'll be our 6th observance this year. And I just wanted to put that on everybody's radar so that you can be thinking that there will be notifications of events coming your way throughout the next few months. We know there's an association between behavioral health and trauma, of course, and it's one of those cross-cutting issues. So we like to really promote awareness of the impact of trauma.
Right. Well, if no one has anything else, like I promised Miss Cornish, we start on time, we end on time. Okay, it's that good lunch hour, so we gotta make a move. But I appreciate everyone's time. I appreciate the rich conversation. I appreciate the feedback. You know, the SEOW works because of the folks who show up and participate, and the emails back and forth, and the deep conversations. So I appreciate it all. My email is in the chat. If you're not already receiving the newsletter and you would like to, please reach out. We're happy to do that. We oftentimes will put national data news in there, local data news, upcoming webinars, data products and other things in the newsletter. So please, if you're not already signed up, let me know and we will certainly get you signed up. Like Emily said, it's every 3 weeks, so we're not bombarding you with information. And our next SEOW meeting will be in September. We will work as we always do on the new Epi report over the summer. So please get your thoughts in sooner rather than later, because we will start making moves to work in that direction. All right. Anything else before we close out? All right. Well, I appreciate you so much. Everyone have a great rest of your day, and we'll talk to you later. Thank you.
Have a good day. Stay safe
Thank
and
you.